So first I will begin with a chest x-ray. Okay, please have a look at this chest x-ray. We will come back to this x-ray and combine whatever we have learned in the next 15-20 minutes and see what is the interpretation of this x-ray. Not a very difficult one, but there's a rather interesting twist to it. Okay, so first is ordering a chest x-ray. We often order chest x-rays for a patient, and most of the time, at least what I do most of the time, I just write CXR. I'm guilty of that, I must admit. So I do not properly prescribe a chest x-ray. So these are the steps that we must follow when we establish or when we prescribe or write a chest x-ray. One is that we must identify the patient and writing it for the proper patient. It's important when we are seeing a patient in the wards, then we are writing it for the correct patient. Indications for the procedure, we should know why we're offering it. Often we just write a chest x-ray just because anybody is old, or just because somebody is old, or from some very small complaint, but chest x-ray should be reserved only for patients who deserve it. We're not going into detail for indications of chest x-ray. What you have to write is the position in which we want the chest x-ray to be done. It can be done either in the supine position or in the erect position. If it is anything is not said, then you have to assume that the x-ray is to be taken in the erect position. However, there are certain, especially for patients who are very sick or has a trauma or sick lying in an intensive care bed, it may not be possible for them to take an erect chest x-ray. In those patients, a supine x-ray will be indicated. The other thing is anterior posterior view or a posterior anterior view. If anything is not specified, then the x-ray should be a posterior anterior view. That means the chest x-ray would be coming from the posterior aspect and going towards the anterior aspect, and the x-ray film, nowadays there is no film, just a digital receptor, just like our cameras. So that lies anterior to the chest. There is a gap between the person, the x-ray generated, and the person, and the film or the receiver or the whatever, let's call it the film. The film is kept flushed with the patient's chest and the patient stands erect. If we are taking the x-ray in a supine position, then it will be an anterior posterior view. That is, the chest x-ray film will be behind the patient or in approximation with the patient's back. Usually if anything is not specified, then the chest x-ray is taken in an end inspiration, because end inspiration inflates the lungs and we want the lungs to be nicely visualized. However, there are certain situations when you want an end expiration. That means less amount of air within the thoracic cavity, especially if we want to detect some abnormal air somewhere. So if we can reduce the normal air inside the lung and increase its density, then abnormal air, there is a contrast between those two things. Anything that is visible on a chest x-ray depends upon the contrast between two adjacent pieces of tissue. So if the patient is suspected of having a pneumothorax or atelectasis or some kind of air trapping, then an x-ray in an end expiration position at the end of expiration is justified. Well, shades of gray, not exactly 50, but only a few ones. This is a rough guideline towards looking at a chest x-ray and looking at the shadow. It's a gray scale, what is to be expected depending on the kind of shadows. On the very left, we have a black area, that means it is a completely radiolucent area. So that means what is there is air. And if it is a dark gray, then it is also very lucent, and the most likely tissues is fat. So we'll find fats around the skin areas and that. Soft tissue is lighter gray, like the heart and some of the blood vessels, etc. would be softer tissues. Bone would be almost near to white, slightly off-white, and something which is the whitest would be a piece of metal. There are various things which are implanted in the chest, so they will appear as white. We can also have artifacts like coins in the patient's pocket, or maduli or tabik, this kind of stuff, or foreign bodies like bullets or ingested materials anywhere within the thoracic cavity.